topic in pregnancy, that is about maternal cardiac arrest and perimortem cesarean section. Okay. So this is also one question which can be both in practical and theory. Okay, so as we all know, maternal mortality is a key health indicator. Okay, especially with majority burden, when 120,000 still having this issue. Okay, so cardiac arrest in mother usually has a higher mortality for mother and also the fetus. Okay, so the WHO estimates roughly around 25% of deaths in India are usually because of maternal mortality. Okay, so that is something that we need to look up. Okay, so why is it different compared to any adult cardiac arrest? Okay, the only reason is because here both mother and the fetus is at risk, and we are going to treat them. Usually, maternal cardiac arrest, unlike an adult cardiac arrest, involves a pediatrician or a neonatologist, obstetrician, intensivist, and an anesthetist. Okay, so usually it's a multi-department or multidisciplinary approach for while managing. Okay, you need to call for help at the earliest. So, what are the risk factors associated with maternal cardiac arrest? Broadly, we can categorize into cardiac and non-cardiac. So, cardiac risk factors for maternal cardiac arrest are congenital heart disease with pulmonary hypertension, valvular heart disease, cardiomyopathy, coronary artery disease, recent ACS, connective tissue disorders or vasculitic disorders, prior history of cardiac surgery, recent pulmonary embolism. Okay, all of this is a cardiac risk factor for maternal cardiac arrest. Non-cardiac are hemorrhage, sepsis, eclampsia, and anemia. Okay, so these are the risk factors. Coming to etiology, what are the etiology? We all know there can be two ways that you can categorize the etiology of maternal cardiac arrest. It can be by ABCDEFGH or Biochops. Okay, remember when we're talking about adult cardiac arrest, we usually talk about 5Hs and Ts, right? So along with them, then you have to think of all these issues. Okay, so each A stands for anesthesia accidents, B stands for bleeding, cardiovascular causes, drug causing maternal cardiac arrest. Okay, embolic events like pulmonary embolism because there is an procoagulant state, any sepsis causing this. Okay, along with your 5Hs and Ts, and hypertension, especially hypertensive disorders of pregnancy. Okay, so usually all of this is what we need to remember. So it's similar. The other mnemonic is Biochops. Okay. So if all of this is present, is there an early warning sign which can be used as an objective tool to pick up these things? So most of the times we have mothers admitted in the labor wards, in the wards as well, right? So is there an objective tool that can help us? Yes. Similar to the Muse which we use, we have an obstructive early warning score as well. Okay. So usually it has to be done. Okay, on an hourly basis, and whenever the score is more than 3, then probably it has to be appraised to a doctor, especially probably an obstetrician. Okay, or else if there is any other intensive care being involved with obstetrics, they have to be appraised. So what are the parameters that are involved in obstetric early warning score? It's temperature, pulse, respiratory rate, systolic blood pressure, urine volume. Okay, mode of birth. Okay, most of the other parameters are similar to what we use in Muse. That is your temperature, heart rate, respiratory rate, SBP, and consciousness level. Urine output is also there in Muse. The only additional part here is the mode of delivery. Okay, so surgical, we all know probably the blood loss is high. Okay, so that is the reason it carries a higher risk. Like that is 2. Vaginal delivery, probably it is anticipated to have a lesser blood loss, so that is why the score of 0 to 1 comes there. Okay, so this is about an objective tool to assess high risk mothers for patients deteriorating in the wards. Okay, so usually a score more than 3, you have to call a doctor. Score more than 6 is associated with a higher mortality, roughly up to 6.8%. So why is maternal cardiac arrest different? We all know the maternal physiology is very different. Okay, I'm not going into details of physiological changes of pregnancy, but this is something that we have to know. So we all know that mother is a procoagulant condition, hemodiluted state. Okay, and there is increased demand. Okay, supply is always being challenged, and there is always change in the respiratory and the circulatory systems. Okay, so the reserve in the mother is usually less as compared to any other adult. Okay, so this is one of the major reasons why maternal cardiac arrest is discussed as a separate entity. Okay, even in ACC-ALS. Okay, so coming to the basic life support and maternal cardiac arrest, okay, so it is similar to what we see in any other condition wherein a patient has a cardiac arrest. So you have to activate the maternal code blue, okay, or else if you have a bystander approach, you have to check for unresponsiveness, check for breathing, like how we do, check for the pulse, and then you have to activate the code. Okay, so usually it needs a special consideration because it's an obstetric patient. Time is of the essence. The time of cardiac arrest has to always be documented. Okay, so if spontaneous circulation is not restored after 4 minutes of effective resuscitation, probably this patient warrants a cesarean section if the patient is in a hospital based setting. Okay, obviously if the patient is in the public, probably we cannot do, but yes, definitely if it's in the hospital based setting, we can think about it. Okay, so coming to what are the nuances associated with maternal cardiac arrest. Firstly, chest compressions. Okay, the positions of the hands for the chest compression is similar to what is seen in non-pregnant. Okay, so there is no change in the position of placing. Okay, so why they said this is based on multiple MRI scans which they had collected over a period of time. They saw that there was no significant vertical displacement of the heart in pregnant state. Okay, so that is the reason they said there is no change. Okay, on the other hand, how do we do about compression fraction, depth of compression, etc.? Everything remains to be the same like we do in any other adult. Okay, only thing is, remember, the important thing is here the reserve is less, so you have to act quickly and you're trying to save 2 lives. So the depth should still be 5 to 6 centimeter of depth. uh, Rate should be 100 to 120. Compression ratio to ventilation ratios should be 30 to 2. Okay, always have a cardiac board when you start. Okay, initially you might not have it, but then later on during the compressions you should place them. Okay, and similar to what we do in adult cardiac arrest, the interruption between compressions should not be more than 10 seconds. The other important thing which happens here is the uterine displacement, which usually we don't see in other adults, right? So here, because there is a gravid uterus present, there's always a issue of aortic compression which can happen along with caval compression. So aortocaval compression can be caused because of a gravid uterus. So when does this happen? Is it there in the early trimester? Unlikely in the earlier trimester. Once the uterus becomes a abdominal organ from the pelvic, it comes into the abdominal compartment. So the patient here at the gestational period of more than 12 weeks can have aortocaval compression. Okay, so in such patients you should do a left lateral uterine displacement, okay, when you're implementing CPR. Okay, so it's always a good practice to do this in all gestational age, because most of the time you would not know the gestational age. Okay, so that is the best practice statement we can give, but definitely if at all you know it is more than 12 weeks, better to give LUD, that is your left uterine displacement. Okay, so how do we do that? It is usually uh, depending on where the provider is standing. Okay, one hand technique or the two hand technique, as it is shown in the diagram. Okay, so whenever you're giving a two hand technique, you stand on the left hand side. One hand technique, you stand on the right hand side. So this is one practical thing that if you can remember. And adequate shift whenever you're thinking about is to move it up to 1.5 to 2 inches. Okay, so if you move it by 1.5 to 2 inches, it helps optimize the venous return, thereby improving the stroke volume. Okay, especially during CPR. Okay, so when you're doing the displacement, it should be leftward and upward towards the ceiling. So that is what is usually the way to move the uterus. Okay, coming to airway management. So I told you earlier the reserve is very less. So the thought of intubating such patients, especially in a cardiac arrest, should have a lower threshold to secure the airway. Okay, so remember that part. Okay, and always there are other things like we have been studying from time immemorial. It's a full stomach, decrease the reserve. Okay, so chance of aspiration is very high. All of this have to be kept in mind. Okay, so the airway should always be open using a head tilt chin lift maneuver unless otherwise contraindicated. can try and use adjuncts, but better to avoid a nasopharyngeal airway because these patients are prone to have bleeds. Okay, they will have a friable mucosa, so it's always better to avoid a nasopharyngeal airway. Oral airway should be okay. Okay, so that is one of the important things associated with airway management. Okay, so always, probably if the patient is a little obese, try and have multiple size endotracheal tubes, etc. These are the things that we need to be mentioning in airway management in a maternal cardiac arrest. Coming to breathing, we know FRC is low, oxygen demand is high, shunt is high because of gravid uterus. Okay, so with all of this, Bagmar's ventilation should be there, but do not delay intubation. Okay, so ventilation rate, don't increase it to more than 8 to 10, again because alkalosis will again cause a lot of fetal and maternal complications. Okay, so that is very important. So don't hyperventilate this patient. Okay, 8 to 10 breaths or maximum to 12 breaths is more than enough. Don't cause iatrogenic respiratory alkalosis. Okay, this is one important thing I would want you to write in breathing when they ask you. Okay, so larger tidal volumes decrease the cardiac output. Again, they also can cause fetal acidosis. So be very judicious when you're giving ambu breaths. Coming to defibrillation, it should be used as soon as available. The energy joulage is similar to what we see in non-pregnant patients. Okay, it depends on the type of rhythm you're giving. Okay, there is no contraindications for cardioversion in mother. Okay, so the only thing is, before giving a cardioversion to this patient or a defibrillatory shock, make sure that the fetal cardiac monitors are removed. Okay, so because there is a theoretical risk of transmission to the fetus. Okay, so that is one thing they have mentioned. Okay, but still things cannot be proven. But by guidelines way, they're telling you not to continue with the CTG when you're doing it. Remove the CTG and then give the shock. AEDs can also be used wherever it is available, because that will be much, it will help us analyze and also shock the patient. Okay, coming to ACLS. Okay, in these patients, I spoke about airway. The next important thing, airway, breathing, and is majorly covered. Okay, so the most important thing I told you, don't use an nasopharyngeal airway. Other one is tubes. I told you multiple sets you have to have. Better to use 0.5 to one size lesser as compared to a non-pregnant person. Okay, if so, usually what they say is use around 7 of. Okay, for an adult well-built lady. Okay, otherwise 6.5. It depends on the patient again. Okay, so this is one thing about the airway. Okay, keep a smaller size to avoid trauma. That is a major take-home point for airway. Okay, other one is IV drugs. The first and important thing in IV access securing is it should be above the level of the diaphragm. Okay, because again, if the gravid uterus is present, if the circulation is not going, then most of the drugs would not be circulated properly. So that is one of the practical reasons why they say secure an IV access above the diaphragm. Okay, if you're not getting it, emergency IU access, that is your intraosseous access, can also be accessed. Okay, dosing is very similar to what is in a non-pregnant patient. There is no change in doses for the drugs. Okay, remember, the most important thing you have to remember is, one is the size of the airway should be less. The other one is IV access you should secure above the diaphragm. Okay, and the left uterine displacement. If at all you have known the cause of cardiac arrest, you have to go ahead and use the particular antidote. There is no contraindications for using an antidote in maternal cardiac arrest. Remember, mother is the priority over the child in maternal cardiac arrest. Its fetus is an added bonus if we save it. Okay, but yes, when mother has a cardiac arrest, mother is the priority that we give. Okay, that is a non negotiable aspect of maternal resuscitation. Okay, so this table, I think so, will help you understand what are the difference between a non-pregnant cardiac arrest resuscitation and a pregnant cardiac arrest resuscitation. Okay, so if you can go see this, majorly we are not seeing much. What they say is the airway that I've already mentioned. Okay, one left uterine displacement, lesser reserve. Overzealous ventilation can cause acidosis. That has to be kept in mind. IV access should be above the diaphragm. Okay, always keep a watch for drug toxicity. If at all they are present, then you have to give particular antidote. Okay, so this is about the differences between a non-pregnant and a pregnant cardiac arrest. Okay, so the algorithm is call for help, LUD, start compressions at the earliest. Okay, compression depth ratio all of them, drugs, defibrillation, everything is the same. Okay, so only when you're giving a defibrillation, if you're using AED, etc., remove the fetal monitors. Okay, by and large, you can remove the fetal monitors as soon as the maternal cardiac arrest happens. Okay, that will be an easy way to go ahead. Okay, so if at all you do all of this, you have addressed your A, B, C, D, E, F. Okay, all of these causes for cardiac arrest have been ruled out. Then, if you are achieved ROSC within 4 minutes, good. If not, if it's more than 4 to 5 minutes, probably you have to think about calling the neonatologist and going ahead with the perimortem cesarean delivery. Okay, again, we need to have a lot of team who has to coordinate and do this. It's very easy when we tell in a flow chart. Okay, but there are a lot of issues associated with this when we're taking a call. It has to be informed and then we have to go ahead. Okay, so routinely there is no guideline telling that you have to do it. Okay, that is one thing. Most of us will have the doubt, do we always have to do it? No. Okay, so coming to the guidelines from the ACC-ALS. Okay, so what are they telling? Like good recommendations are, again, you have to have a team, start the resuscitation at the earliest. Resources show wherever for perimortem CS is there, you can think about it. Okay, especially when the patient is in the second half of gestation where the fetal maturity would be good. Okay, in such patients. Okay, again, protocols for out of hospital cardiac arrest have to still be made available to think about resuscitating even at the out of hospital cardiac arrest state. Okay, so by and large they're telling it's a team based approach, nothing great about the evidence for this, because this is all based on case reports. Okay, so most of the other thing is about targeted temperature management. So what they're telling is whenever the patient has achieved ROSC, in such patients, better to do the TTM like we do in any other case. Okay, keep the temperature between 34 to 36 degrees Celsius. Okay, don't need to induce hypothermia, etc. Go ahead, get your other workup like a cardiac workup, etc. Probably based on the diagnosis, you can go ahead similar to a non-pregnant patient. Okay, so this is again level one recommendation. Coming to role of ECMO, there is still no widespread evidence for initiation of ECMO. Okay, because a lot of parameters will be haywire. Okay, it is not shown great benefits. Again, to talk about evidence for this, it's really difficult because you do not have that many cases that we are that that are being done for this. Okay, so the best way to do is if the ACLS is less than 10 minutes, if you feel that the patient is getting a rhythm back and then going back again and back and forth, probably at that time you can convince them and see for the benefit of doubt. Okay, by and large, as of now, currently with whatever data is available, there is no evidence for VA ECMO in patients with maternal cardiac arrest. Coming to the last part of this talk, that is about perimortem cesarean section. So perimortem cesarean section, I told you, after 4 minutes of a CPR, if you're not able to get a ROSC, then at the end of fifth minute is what they're telling you to deliver the baby. Okay, so a cesarean section performed during maternal cardiac arrest or during impending maternal cardiac arrest. Okay, so it does not mean that majorly you need to understand this. The primary goal of perimortem CS is to increase the chance of survival for the mother. Okay, and potentially it might improve the fetal survival. Okay, but again, the primary duty for this procedure is aimed at maternal mortality reduction. Okay, so it is only to improve the circulation and improve chances of uh, achieving ROSC. Okay, so the whole gravid uterus might be one of the reasons why all this might be happening. So that is one area where we are looking at it. Okay, so again, it is for improvement of maternal, not the fetal resuscitation. Again, it is offsetting the compression of the IVC, helping the return of circulation. Okay, it also helps improve the respiratory mechanism because the major effect of the gravid uterus on the diaphragm would be lowered. Okay, so by and large, this was actually introduced in 1986 by Carls et al. Lot of case reports have been studied, but as of now, also, okay, ACOG, everyone do not have any recommendations for perimortem cesarean section. Okay, so they say what even the ACLS criteria, what they say is if there is a cardiac arrest, continue all your resuscitative measurements like your left uterine displacement, etc. Okay, look for causes. If you're able to do all of this and you still feel it is futile at the end of fourth minute, then consider doing a PMCS. Okay, so to accomplish the delivery ideally within 5 minutes at the time of arrest is reasonable, but again, practicality, if they're seen, there is no larger recommendations for PMCS yet. So, what are the recommendation by the RCOG, that is the Royal College of Obstetrics and Gynecology? So, if the fetus is dead, also even then you can go ahead and do it just to see if it can help the maternal outcome. Okay, so anything if it's a pregnancy of more than 23 weeks, probably it can help improve the fetal outcome as well. Okay, the only thing, only essential equipment which is required for a PMCS is a 10 number blade. Okay, so unlike the phenenced incision, a longitudinal incision is what is made. Okay, directly the uterus is accessed and then the fetus is delivered. Okay, so this is about the procedure. Okay, so you have to do the left lateral decubitus incision from xiphoid to symphysis pubis. Okay, so bladder is retracted and a second vertical incision on the uterus. Okay, so that is given to deliver the baby. Okay, so in summary, remember, majorly there are no differences except a few physiological changes in the mother. Only the etiology of maternal cardiac arrest is more. Always secure an IV line above the diaphragm. Use a smaller side airway. Always watch for mucosal injury causing bleeding. Okay. Volume assessment is always necessary. Look for drug-induced maternal cardiac arrest, especially with patients with hypertensive disorders of pregnancy, patients receiving magnesium, patients who have been posted for cesarean or epidural, etc., who might develop local anesthetic systemic toxicity. All of this, okay, these have to be ruled out. Okay, so they are all reversible causes. So if they're picked up, probably at that time you can go ahead and do it. So these are the cases again which can be taken as a case for ECMO as well, okay, wherein there is a definitive cause of cardiac arrest. In such patients, you might even think of doing an ECMO if they are having ROSC which is achieved but not sustained. Okay, so this is what you need to understand. So PMCS after 4 minutes, fifth minute you have to do it. Again, no major recommendations. If done, mostly it is focused on maternal outcomes, not the fetus. Okay, thank you.